Minimum time, 60 seconds for any cartridge of local anesthetic. Time yourself. Colleagues, time themselves. If you're ever giving a full cartridge of anesthetic in less than 60 seconds, it's a long time, trust me. A lot of my anesthetics take me 3 or 4 minutes to give, and I warn the patient of that before the time. I say, this is going to take much longer. However, when I take that needle out, my drill goes straight into that pulp.
I'm going to replay this to my nurse. Because I'm that slow as well, and then my nurse sometimes thinks, Jazz, like every other dentist I've ever worked with is just give the damn injection. You know? Welcome back, Protrusive, to Articaine ID Blocks Part 2. How good was Part 1 thanks to Dr. Wayne Williams? What I love about bread and butter episodes like these is the engagement it gets from the community. So you guys, Protrusive on the Instagram at Protrusive Dental, had some really interesting things today. Like, for example, Coney Caravotas, we met in Brighton and also at the Finlay Sutton course. Hope you're doing well. She said that she hasn't done an ID block since 2009. So that was 14 years ago. That is bloody impressive, right? Like I told you, I do about one a month. Coney hasn't done one since 2009. She said, buccal articaine infiltrations all the way. And there were loads of comments just like that about how we're all getting really good results with buccal articaine. But of course, Dr. Wayne Williams suggested that it's only really appropriate for single tooth procedures. But I know many of you, including myself, on many occasions use it for quadrant dentistry in the lower molar area. Now, I wouldn't use it, like I said in the previous episode, of people with large bones, large heads, big bony exostoses. But for the average person, I think it does work well in my hands, and that's what it's all about. Don't change your technique if something is working well, unless there's more efficiency, more safety involved, or lower cost involved. But if you're not compromising a lot on those areas and something is working well in your hands, I wouldn't change anything about your protocol as long as you're safe, efficient, and cost effective. So more power to anyone who's getting great success with buccal articaine. I personally will say that by putting it in the attached gingiva. Now, something that it's Dr. Albert also said on Instagram is the importance of attached gingiva. I find that the attached gingiva retains it, and probably by going in the attached gingiva, I'm entering that coll area that Dr. Wayne Williams talked about in the first episode, and therefore these emissary canals, these holes in the mandible to allow our anesthetic to get in the right place. So if you're not getting good results like our colleagues are with buccal articaine, consider putting some in the attached gingiva instead of just going supraperiosteal near the apical area and expecting it to diffuse into the bone. Like Wayne said in the last episode, it's not as simple as that. One thing I have changed about my technique after talking to Dr. Wayne Williams is, although I'm very slow with my anesthetic, I sometimes speed up towards the end for a subperiosteal, which I won't be doing so much anymore. But I think the key point was just always keep it slow and reduce the pressure. Another thing actually I will be changing, because a lot of things I won't be changing because it's working well in my hands, but a big thing that I'll be changing is as a result of this part 2. You're going to find it pretty interesting what happens in part 2. Just have a listen or have a watch if you're on the app or YouTube to this part. I've got a few videos I've taken of me giving a lingual infiltration, and like if I've done a crap job and I'm doing something dangerous, say it live on air. I mean, we're not live, but you know what I mean? Say it on the podcast. It's a learning thing for me. And I thought, okay, wow, I get to show someone who's so experienced and written about local anesthetics, and I get to show you this video. So please, if I'm doing anything wrong, I want to learn, and I want everyone else to learn from if I'm doing something wrong. If I'm doing something right, please let me know as well. So a cool segment of this episode will be me showing you those videos, which I'm very excited and nervous about. So actually show Dr. Wayne Williams the technique of giving a lingual infiltration the way I have seen a specialist oral surgeon do it. The story is that I was shadowing a oral surgeon, and I saw him do this very interesting lingual infiltration, what I thought it was at the time, and I've sort of copied him. Okay, he's a specialist, he knows what he's doing, so I've been copying him, and I've been getting, okay results. But I had this doubt in my mind. Is this something that could be made safer, and is it really respecting the anatomy in the best way? Is there a better way that I could give this lingual infiltration? Do you remember way back when, if you're an original Protrusive, you might remember episode 37. That was 3 years ago, my goodness. We had Dr. Shazmam on, and what we did is live on the show, I got him to critique my website, right? And it was embarrassing because my website sucked, and it still sucks because I haven't updated it, right? But it was an interesting and cool thing to do, and I was happy to do it. And it was embarrassing for me, but it's fine. I'm happy to put myself out there for you guys. Now, I did the same thing here, but with a really high quality clinical video that I recorded showing him how I do my lingual infiltrations. And so the protrusive dental pearl is don't do what I did. The technique that I showed him is not a recognized technique, and it shouldn't be used use. And even though that oral surgeon did it, Dr. Wayne Williams, whose opinion I highly trust, told me there's a better way, which that's why I said I'm going to be changing my technique. Now, I'm not going to just expose myself and embarrass myself willy-nilly. This is only for Protrusive Premium members. So if you're on Protrusive Premium, you can see the whole bit where actually entire video, the same video that Dr. Wayne Williams saw, his reaction to it and his feedback in terms of what I should change. I'm happy to make a fool of myself and share that with you guys. So if you're on Protrusive Premium, you'll get to see all of that. If you're not, then it's okay. I still love you. I still respect you. But you have to understand the feedback that I got in the video that I showed him was absolutely golden and well worth the cost of a Nando's per month. And to give you a teaser, this is the way that Dr. Wayne Williams reacted.
I'm sorry, I've never seen that described anywhere. I'm not sure it's needed. I'm not sure what the benefits of it are. Yeah, I'm not in favor of that technique.
So let's join Dr. Wayne Williams to continue on that cliffhanger we left you at the end of part 1. Should we fear the large-headed redhead? Is that true or false? Is that a myth or is that real? And any strategies to help the large-headed redhead if it's true?
So I'm not aware of the redhead. The large I can kind of understand because it comes back to anatomy and physiology and understanding. And that's always my starting point. On all the courses I present and all the teaching I do globally, it's always go and learn the anatomy, number one, then understand the physiology, then the chemistry, and then we go to the techniques. But it has to be in that order. Don't try and go for the techniques and then work your way back. You have to have the anatomy, physiology, and pharmacology behind you. But so there's different ways I would approach a redhead from now that I've heard you and Lincoln say that. And great program by Lincoln, by the way, with yourself as well. High respect to him. And basically, the guys I'd be more interested in for you and other colleagues in this country would be class 3, people with class 3 mandibles. Well described I brought this textbook along because this is what changed my life 25 years ago.
Just for the listeners, can you just say the name of it for the listeners who are listening?
Sorry, because I know it's around Hazards of Local Anesthetic Injections by Daniel Barnard, same type of Barnard who did the first heart transplant, possibly a family member, a gentleman who I learned almost everything I know about local anesthesia from, certainly the hazardous approach to it, a valuable piece of literature. But basically, he speaks more about class 3 patients having a slightly higher lingula, and then certain racial groups, Chinese people have higher lingulas, Asian type orientations in terms of their lingular position is slightly higher. And certainly some of our tribes back in Africa have different positions and much stronger class 3 mandibles and thicker bone, of course, and of course you make your judgments according to that. But often what people miss is look at an OPG. If you've got an OPG of a patient, you can actually see the lingula often on that OPG, and you can then figure out from a cusp position in the mouth. You take a cuspal measurement on the OPG, say the upper 6, and you measure that's 2.3 centimeters, 23 millimeters. Then immediately you can then take your fingers and estimate at 2.3 millimeters, put it in the mouth and say, right, that's where the lingula is lying up at that point, and then get yourself to go in. Just giving yourself landmarks, local landmarks.
That is a fantastic tip that someone could apply, and that's very useful. So really, case by case, and so maybe not the redhead, we don't know, but large anatomy, thicker cortical plate kind of thing, that may be a concern. But I guess the real clinical tip there is just aim higher, because they probably have a higher lingula, and that is a real applicable tip. Now, we talked about anesthesia failing, and one of the reasons I do a lingual infiltration is to prevent that, right? Now, you're probably going to say that don't bother with lingual, it doesn't work. Okay, that's totally fine. I'll stop my practice immediately if you say it. But what are your thoughts on lingual infiltrations to supplement and bolster your buccal? Is there any science behind it?
So again, if you're using the mesial distal approach, then the lingual approach probably becomes less utilized and less valuable. I think a couple of things with lingual. First of all, I'm not sure that I share concern necessarily about anatomy in the lingual domain. So yes, we've got the lingual artery. I think the more bigger concern is the access to the lingual area. So you've got a tongue in the way. You've got a curve of Spee and curve of Monson with your teeth curving in the lower jaw. So you're trying to get under something rather than with clear vision if it's directly in like that. Whereas from the outside, everything's open. On the inside, you're trying to get your visual access to the lingual is always limited. Never mind your tactile and dexterous access to that area is extremely limited. So I think your ability to deliver drugs successfully in the lingual domain, certainly in the lower jaw, is limited. Palatally, in the maxilla, it's a completely different ballgame. I do predominantly palatal anesthesia. That'll shock you a little bit more. So I probably do more palatal anesthesia than I do buccal anesthesia in the palate. And again, if I ever get to share some of my anatomy lectures and work we've done, it's unbelievable how porous the maxilla is. But to come back to your lingual, I'm not scared of the anatomy, but I am more concerned about access. So the only time I would ever go lingual is if I needed the soft tissue anesthesia as opposed to dental anesthesia. So I would always use buccal infiltrations, as you've suggested, and I still think that's an excellent technique, but it has to be using articaine. I wouldn't bother too much with lidocaine, lignocaine, and I definitely wouldn't 2% drugs, and I definitely wouldn't be bothering with a non-adrenaline mepivacaine, Scandanest and others. It's just got no value, in my opinion. You need the 4% articaine for those.
Amazing. Well, should we do the bit where I'm going to expose myself a little bit? And honestly, it's all a mentoring. It's live
Go
mentoring.
for it.
I'll show you it. And if I'm doing something silly, please tell me. And I'm happy to learn. So this is the part of the episode where I show Dr. Wayne Williams my technique that the oral surgeon taught me for a lingual infiltration. And he completely lays the smackdown on me and gives me some valuable anatomy lessons, which I pass on to you. So if you want to check out that, as well as hundreds of hours of CPD and premium content, which I'm constantly uploading month by month, do check out protrusive.app or on Android, iOS. But you can actually go and view it on your laptop as well. The website, again, is protrusive.app. Let's continue with the episode.
And around proper inferior. I think if people are trained properly in the inferior alveolar block technique, we should be using that with articaine.
Well, I certainly feel much better today. I'll speak to you about ID blocks in general. I think, and because you see all the stuff that we talk about and what's posted on social media and also in the BDJ, etc. People are dentists, young dentists especially, are more and more afraid of ID blocks. But I can tell you now, I thank you so much because I feel much better about it. I felt like this is the right thing to do, to phase out of ID blocks. I thought that was the right thing. But from speaking to you, I feel way more confident about going back to ID blocks. So I thank you for that.
Pleasure.
The next question I had is adrenaline being avoided for certain patients. Is that a myth, or are there some patients that we should be avoiding adrenaline on?
Very good question. And again, I think appeals predominantly to our younger colleagues, newly qualified colleagues. It's just amazing going through this talk today with you, Jazz, about all the fear. I almost feel like we're in a political arena here for a minute, but there's just all this fear mongering and don't do this and don't use that drug and this will happen and that will happen. Well, the first point about adrenaline is I think we lose sight often of kind of where we are with that. Adrenaline is produced by our cells in our suprarenal glands. Our body produces adrenaline and tons of the stuff, much, much more than you can ever imagine to be in a local anesthetic cartridge. So we produce a lot of adrenaline. So nobody in the world that I'm aware of to date is allergic to adrenaline.
Yeah, I'd love to be a fly on the wall who told you that I'm
and who's still breathing. So those who are not breathing, they might not be, but they might have been allergic to adrenaline because then that's what causes the problem. But the truth is no living human being can be allergic to adrenaline, not one that I know of. So any patients that do tell you that at any point, you need to probably run away because they're a ghost or something else. So once you've told a patient that, I think we have to be highly respectful of the fact that a lot of patients will tell you that as a result of a potential vasovagal attack previously with the giving of adrenaline. And what will have happened there was the patient will have a vasovagal, they'll feel faint, they'll pass out, they'll feel all the symptoms related to that. And at the end of it all, the dentist will go, oh, I'm never using adrenaline for you again. That's what I used for this time. And the patient goes, oh, it's because you used adrenaline. Right, so that's where the problem starts. The next thing is almost all of those cases are intravenous or intraarterial injections. So because people are not aspirating, and because aspiration is so non-effective in almost all anesthetic devices other than the wand, even all the quick sleeper, all of those, because they have a certain mechanical aspiration technique, the wand aspirates from a foot piece. So I take my foot off a pedal and the device aspirates. Every other device has to have a hand attached to it some way or another, or a needle or a lever pulling back. So you're always going to have the potential for a false negative. But the point I'm going to make here is adrenaline, if given at the right speed, go and look back at the textbooks, how fast, minimum time, 60 seconds for any cartridge of local anesthetic. Time yourself, colleagues, time themselves. If you're ever giving a full cartridge of anesthetic in less than 60 seconds, it's a long time, trust me, A lot of my anesthetics take me 3 or 4 minutes to give, and I warn the patient of that before the time. I say, this is going to take much longer. However, when I take that needle out, my drill goes straight into that pulp.
I'm going to replay this to my nurse. Because I'm that slow as well, and then my nurse sometimes thinks, Jazz, like every other dentist I've ever worked with is just give the damn injection. You know? So I'm glad.
So if your needle's in the wrong place, you're intra-arterial, or if you're intraosseous even, and you go in at speeds that these drugs are not designed for, you're going to have vasovagal attacks. And it's then when people go, and it is then when the adrenaline will play a role. So the adrenaline will play a role in those cases. It's less likely to be a problem. In fact, almost not going to happen if you're using mepivacaine 3% or you're using any kind of non-adrenaline drug. Cytonest and Felipressin we need to come back to, separate point in a moment, because that's a whole different ball game that I'm going to share something with you with. But the truth is with adrenaline, given safely, given correctly with good aspiration, making sure you're not intravascular, given over at least a minimum of 60 seconds for 1.8 milliliters of a drug. If it's a larger cartridges, the 2.2s that we have in this country, we need to go even slower, minute to a minute and a half. Then adrenaline usually doesn't play a role. Now, I have, in my entire practice of thousands and thousands of patients that come to me from all over the world, I have 2 patients who I don't use adrenaline on, and neither of them are proven medical cases of not to use adrenaline. But I've experimented with that, if you want to use that word, where I've gone, listen, I'm the guru of local. I'm going to show you, I will get this right slowly and all the rest of it. And they still have some form of excitement or reaction. It's not a vasovagal attack, but they don't feel well. A lot of it could be psychosomatic.
Yeah.
I can't prove that it is or isn't psychosomatic. But in 2 cases, I say to the patient, look, we're going to use mepivacaine or Scandanest 3%, no adrenaline. However, if you require a procedure that requires a long period of time that I need profound anesthesia and you're going to be jumping around in the chair, then we're looking at sedation, or we're looking at hospitalization, or we're looking at something else where I can then monitor your blood pressure and pulse rate with a pulse oximeter, and I can make sure that you're not having some reaction to this adrenaline. But effective anesthesia, it has to be, and I think that's the takeaway from this concept is you have to always put good, profound anesthesia ahead of everything else. Now, even if that means that a patient has a mild tachycardia for 30 seconds, whilst you're giving that anesthetic and you prepared for that, you monitor it with a pulse oximeter, the patient knows it's going to happen and it's all over and you can control it. And again, slowly and small amounts. But I'm not aware of anybody who genuinely can't have adrenaline.
Well, what about cardiac risk patients or cardiac health? Because that's the one where, if someone's had a heart attack some time ago, they have a stent, and then automatically we think, avoid the adrenaline as a thing. Is that a thing?
Wow. Okay, so I want to just read something to you because this is something I'm faced with quite a lot. People ask this question. So I'm going to read you 2 things, if I may.
Please.
Cytonest. Is that something you'd possibly consider or would have considered in your education?
We have that, yes, absolutely. Okay. We were taught that if they can't have adrenaline because they're cardiac arrest, then maybe give a different type of vasoconstrictor.
So, Jazz, I'm going to hold up 4 cartridges. I especially got these ready for this sort of talk. Can you see those?
Amazing.
Yeah. Now, 2 of them are the same thing. They're just articaine in a 1.4 or a 2.2 mil cartridge, only because manufacturers run out, etc., etc. And then the other 2 are lignocaine, 1 in 80,000 adrenaline, and the other one is the Scandanest 3% mepivacaine, no adrenaline. You will not see Cytonest or Felipressin in my clinic, and you haven't seen that for at least 20 years, at least the last 2 decades. And the reason for that is, and I quote, Felipressin, Cytonest, is the active ingredient of Cytonest. Felipressin acts on the venular side of circulation with no significant cardiovascular response. It can be seen as a less of a risk in compromised patients. That's according to respected colleague John Meakin up in Newcastle, Rob and Seymour in their book, Pain and Anxiety Control for the Anxious Patient. However, according to Robinson, Pitford and MacDonald in their book, Local Anesthesia and Dentistry. However, Felipressin has been shown to cause coronary artery vasoconstriction and cardiac arrhythmia, and is thus not a benign alternative to adrenaline-containing solutions in patients with cardiac disease.
Wow. I had no idea.
No Cytonest, no Felipressin in my clinic. Forget the risks it holds for pregnant patients. If you're keen on delivering a baby, use a bit of that towards the end of the pregnancy. That could help. But, the octopressin, fedipressin in there. But the truth is, honestly, so
we don't want to give an alternative in felipressin because of those reasons you mentioned. But in that patient who has some sort of a cardiac background, would you then also avoid the adrenaline by giving the plain? So there is fine. So there is a
Scan-Nest,
clause.
Scan-Nest 3%. So for a patient with a known cardiac disease, and there are a whole list of those. I won't go into all of those, but they're well described in the literature. But for patients who are genuine or recent major cardiac surgery, and you're having to do an acute procedure, you're in a difficult position because what actually happens, and this is back to the point I made about effective anesthesia, is that every single time you hurt that patient by not having effective anesthesia or long-lasting anesthesia, their adrenaline levels go sky high anyway by self-induction. So their own body produces far more adrenaline into their body system than you could have injected. And therefore, they're having an adrenaline attack anyway, but it's just self-induced. So profound and efficient anesthesia takes precedent in our clinic for all procedures and should, I believe, in most clinics. Even if that means slow, careful, calculated deposits of adrenaline if you're having to do a procedure over a long period of time. My point is, if you're doing a small DO composite, use your non-adrenaline containing drug, irrespective. I don't use it. I use articaine and lignocaine for almost everything. But on the occasion where I've had the doubt, I'd use that. But if a patient's coming to me for an extraction and I'm in a 50-50 doubt, they're getting articaine in a controlled, calculated fashion.
I'm just in awe. This hour's gone so quickly. It was an absolute pleasure to speak to you today, Wayne. You were so hard hitting. You were so direct, and you really reassured me in a lot of the areas which me and the Protrusive had some misconceptions, and that is fantastic. Wayne, please tell me, like you've done lots of teaching in the past. You're getting into it again because I know you got busy with clinics and stuff. How can we learn more from you?
So. Contact me directly, Jazz. I'm happy for you to give out my details. My email's usually the best way to get hold of me. I'm one of those guys. I get up at 4:30 in the morning. You can always contact me between 4:30 and 8:30. But 8:30, I start with my patients most 4 days a week. But I do clear my emails on a daily basis, and you'll know that from your experience with me. But I clear my emails every single day. And if anybody gets hold of me by email, if you have my mobile number somewhere, you're always welcome to contact me. I do in-house training courses for practices, but I don't advertise.
What kind of stuff do you teach there, like Akinosi,
so
Gowgates, that kind of stuff?
Yep, Gowgates, Akinosis, the CIA, a lot of it around the wand, of course, but a lot of what I teach will be anatomy, physiology, and pharmacology. That's the basis of all the courses that I present.
Wayne, I think any practice is looking for like a team day, right? In terms of something for the clinicians. Local anesthetic is such an underlooked at, but such a key thing. Rather than sending your associates to a composite bonding, I think there's enough of that. Going back to basics, local anesthetics. So do consider giving Wayne a shout because I'm sure you guys have as well. Absolutely love this conversation. Thank you so much. Anything else you want to add?
No, Jazz, as I say, you keep up your good work. I'm in awe of your work and all your Protrusive, I think is the term. I'm very proud to be one of those. And please keep up the good work. And thank you again for the opportunity.
Thank you so much. Well, there we have it, Protrusive. I just realized at the beginning of the episode in the intro, I didn't even introduce myself. So if you're new to the podcast, my name is Jaz Gulati, and thanks so much for making it to the end. That's pretty cool. Lots to be learned from that episode. Dr. Wayne Williams is full of cold, hard facts, which might upset some people because you've been doing things and they've been working, and then suddenly someone throws a bombshell of information which kind of goes against your paradigm. But you have to respect the anatomy, the physiology, and the pharmacology. But ultimately, remember, like I said right at the beginning, it's what works in your hands. So if you're getting good results and you're safe and you're cost effective and you're efficient, with LA, that's what matters, right? If you can do it in a painless way, all the better. So I'm sure you took away a few practice-changing gems, but some things that you might just respect, but because it's working in your hands, that's totally cool to continue the way that you've been going. Now, if you want to claim some CPD, then of course, as a premium member, you can answer a few questions and get CPD for this episode and the last one and hundreds of others. Otherwise, I've got a lot planned this summer in terms of podcast episodes. We're expecting baby number 2. Gosh, by the time this episode comes out, it'll be a few weeks away. So wish me luck, guys, for baby number 2. I hear it's twice the lows and twice the highs. So if I do go radio silent for about 10 to 12 days, you know where I am at. So my team's been really supportive. We've got loads of podcasts in the pipeline ready so that when I get busy with baby, there's still your protrusive fix to keep you occupied on those long and lonesome journeys. Thank you as ever for being a Protrusive, and I'll catch you in the next one.